On behalf of the American Heart Association, I would like to welcome you to the second session of today's Close the Space, Secondary Prevention of ASCVD Care Education Virtual Summit. My name is Natasha Chiafalo, Programs Consultant at the American Heart Association, and I will be your moderator for today's session. All presentations will be recorded and available within the coming weeks at heart.org/ASCVD. Today's presentation is titled Lessons from an Academic Perspective, Sharing Ownership of Reducing ASCVD Risk. It is my pleasure to introduce our panel of speakers for today, Dr. Jennifer Kirby, Dr. Kimberly Dowdell, and Dr. Patricia Rodriguez Lozano. Dr. Jennifer Kirby serves as the Associate Chief in the Division of Endocrinology and Metabolism. Her clinical practice is focused on patients with obesity and diabetes, with a special emphasis on cardiometabolic risk management. She is the director of the Cardiovascular Diabetes Consult Service at the UVA Hospital, which focuses on inpatient management of diabetes in patients being cared for on the heart and vascular services. Dr. Kimberly Dowdell is a primary care physician with the Division of General Geriatric, Palliative, and Hospital Medicine Division at University Physicians Charlottesville and attends the General Medicine Inpatient Service. She was the lead physician for the CMMI AAMC grant-funded implementation project for eConsults and enhanced referrals at UVA, and currently serves as the national content expert for the AAMC. Dr. Dowdell has a deep understanding of EPIC and has led several efforts to improve clinical care delivery, including prediabetes screening at UVA, primary cardiovascular prevention identification, process improvements in Medicare wellness visits, chronic care management, e-visits, and continued enhancement strategies for internal referrals. Lastly, Dr. Patricia Rodriguez Lozano serves as director of the Women's Heart Health Program, co-director of the SCAD Clinic, and associate program director of cardiovascular fellowship at UVA. She's also the Women in Cardiology representative for the ACC Virginia chapter. She has advanced multimodality training, including echocardiography, nuclear medicine, cardiac MR, and cardiac CT. Her clinical practice is focused on women with or at risk for cardiovascular disease, with expertise in diseases unique to women or seen more often in women. Dr. Kirby, Dr. Dowdell, and Dr. Rodriguez Lozano, the floor is yours.
Thank you very much. On behalf of our panel, we're really excited to join you this afternoon. We were asked to partake and sort of share our experiences in an academic institution about how we share the ownership of reducing ASCVD risk, particularly focusing on secondary prevention. Just a little note, the presentation will discuss some current barriers in care and how we've addressed these in our communities. Doesn't necessarily reflect the AHA or ASA's official position, but we certainly do defer to those at several opportunities. We thought we would do some cases to kind of highlight how patients will come into our healthcare system and may end up seeing one of us in a variety of systems and how we might approach that. So we're going to have three scenarios, kind of a variation of the same case, to kind of talk through some things that we thought would be important to this group today. So this is a 64-year-old man who has type 2 diabetes and hypertension, and he is presenting for follow-up after hospitalization for an ST elevation MI. He was discharged on atorvastatin 80 milligrams daily, and his repeat LDL is down at 65. And so we were going to take this opportunity to kind of talk about immediate post-care for heart patients. So Dr. Rodriguez Lozano, can you share our processes here at UVA in terms of our post-MI discharge and how we take care of those patients?
Yeah, thank you, Dr. Kirby. So here at UVA, we offer a special post-MI clinic that is a week after being discharged from the hospital after an event, after an MI all our patients will automatically be scheduled for a follow-up appointment to be seen in this post-MI or heart attack recovery clinic within 1 week of being discharged from the hospital. So the patient will meet with a team of specialists. They have the opportunity to get a one-on-one time with a cardiologist, with an exercise physiologist, a pharmacist, a dietitian, and a social worker. So obviously there is a lot of benefits to have this team approach. And the idea was to have more control, give more control to the patient, and as they, have a more clear recovery map based on an individual need of a specific patients and guidance after leaving the hospital. And I think this is important because empower the patient to regain that control after a period of time, being in the hospital and maybe feeling some kind of uncertainty, or maybe don't even understanding exactly what happened to them. And I think that is really the beauty of this team, has increased the awareness not only of patients about their disease, and many times it's a new condition for them, but also their families, right? And we focus on not only physical recovery, but also, of course, they come with a lot of emotional challenges and even like specific logistic, like insurance coverage for medication. So we kind of address all these things and all these questions, maybe even confusion about their testing or their prognosis after an event. And besides that, we also have a part of this clinic at this program, we have a supervised rehabilitation program. That is obviously, as we know, data have shown that this is very important in the recovery phase after an acute MI. And we know that there is multiple benefit of this in terms of decreasing future MIs and reduction of risk factors, improving quality of life. And usually patients they start in this program 2 weeks after being discharged from the hospital. The time varies. It could be between 6 and 12 weeks of supervised exercise program and provides them safe and supportive environment. And that is pretty much what we have here at UVA.
I'm going to ask you a follow-up question, because I know, having done a lot of hospital work myself, and those transitions of care are often fraught with problems in terms of instructions and patients not necessarily being able to get the medicines that we send them home with. Who is a part of that discharge, or who's a part of that post-MI follow-up clinic? Who are the team members that partake? Are there things like clinical pharmacists or NPs or others that help you do that work?
Yes, thank you. So we have, as part of that team, we have 2 cardiologists, we have 1 pharmacist, we have 1 dietitian, we have a social worker, and we have an exercise physiologist. So on that is a one-time visit. And usually it lasts for a couple of hours. So it's a long visit because you have to see all these different experts. And then after that, it is decided if they will follow up with our practice. But many of these patients, they have already established cardiologists, or they live far away. So they will follow up with, another provider after. So it's really an individualized approach. So we define what are the needs, and after that we give a specific plan for each individual.
And one other follow-up around the cardiac rehabilitation. What we are in an area where we draw from a large swath of we have patients that come to us from a large area. And I know one of the challenges that we often face is sort of access to care where patients are coming from. What are some of the barriers that you all have identified in terms of patients getting access to cardiac rehab? And can you talk a little bit about insurance coverage, or where some of those barriers might be as well? Because it is such a huge benefit for patients.
Yeah, absolutely. So one of the things is, in terms of cardiac rehab, we have identified different programs that can provide this at you know, we obviously are a referral center, so many patients come from 4 hours away, a couple of hours away. So we usually try to refer them to a specific facility that will be close by. Sometimes we have, of course, difficulties to get the right place, but we try. I mean, obviously, we are used to have patients that are not necessarily from close by. And in terms of insurance coverage, that is the importance of this clinic, because many times during a hospitalization, there is no time to, you know, sort it out all these insurance coverage and prior authorization procedures or process. So we try to, in this visit, to sort out all these logistic challenges. And if we have to go through a pre-authorization process, our pharmacists are very well trained on this, because this is what we do, and we know how to try to get those things. And if the medicine cost exceeds you know, what the patient can cover with insurance or by himself or herself, then we decide to change to a different therapy, because the idea is not just prescribe medications, but actually the patients can take it, right? Medications, they don't work unless you take them. So that is all the things that we try to address in this visit, and this a long visit, is 2-hour visit, because there are many things that we have to sort it out.
Yeah, no, that's great. And I know that just from experience in discharging patients on complicated insulin regimens, that and the expense of medications often gets lost in that. It's difficult to manage that transition. So I think that's a really good tool. I wanted to follow up with you, Dr. Daldell, in terms of discussing, because of our system here, how that looks for you as if you have a patient who's admitted to our hospital with an MI and then is followed with the in the MI clinic, what that looks for you down the road, and how do you view that in terms of being the primary care physician?
Right. So because this clinic exists, typically when a patient's admitted to the hospital with a different diagnosis, we try to get them back in our primary care clinic within 2 weeks from discharge, just to make sure the same things that Dr. Rodriguez-Lozano was mentioning. Did they get their meds? Are they taking them? All those types of things. With this clinic in particular, when we have a patient who has an MI and we know is going to be going to MI clinic, we actually just do an outreach phone call to the patient to let them know, hey, Dr. Daldell saw that you had this MI. We just want to check in, but we're going to schedule this appointment 3 months from now, when we're expecting that your cardiac rehab is kind of coming to a close. We heard Dr. Rodriguez-Lozano mention 6 to 12 weeks of cardiac rehab. So we'll typically schedule our follow-up appointment at that time, just to kind of make sure that we're in the loop, that we understand all the medication changes, and that we have had a chance to outreach to our cardiologists if there are any things that have come up in the meantime from their last appointment. So we kind of use it more as a handoff kind of appointment at that point. With our nursing team, making sure that medications are done. And then for patients like this, we do have registries that these patients fall onto into our electronic medical record, which at UVA we use Epic. And so this patient here would be in both our diabetes registry, but also in our cardiovascular registry as well. And then the registries can help drive kind of tools that I can then enroll my patient in. Like right now we have a diabetes health maintenance plan, which then reminds me, hey, I need to check their A1C this often and their lipid panel this often. It's kind of funny when we were talking about this case, we realized we don't have a secondary cardiovascular prevention health maintenance module. And so that's actually something that I think will come out of us just presenting here. And so, just reminding us, like, maybe we should be getting the LDL once a year to assess adherence, and then also just whether or not that statin is giving us the desired LDL reduction.
Yeah, and I think that was a great point that you made, because I think that this is one of those things where we've talked about, you're an amazing advocate for utilizing the EHR to help us be better physicians and care providers. And yet, as we were talking about this, we identified a gap in some of our stuff. So are there other, you talked about the registries and stuff. I think, there's Are there other tools that other EMRs use that you're aware of, or things that other practices can use? I think it's really hard when I'm sitting in front of a patient to remember, oh yeah, I need to make sure I've got their LDL or what. So I think as medicine's gotten incredibly complicated, even particularly for PCPs.
Yeah.
So what are the things that you look at to help you?
Yeah, so the health maintenance tab in Epic is my like best friend as a primary care doctor, and the more that we can tweak that to remind me of the different things that I need to be doing for my patients with different disease processes, the better. For my cardiovascular patients in particular, I know a lot of people take advantage kind of nationally of BPAs, which are best practice advisories. So having the EMR or kind of go, in this case, Epic, go and look and say, hey, this patient hasn't had this addressed in the last 12 months or 6 months, and having the EMR kind of remind you to do those things. Those are definitely engaged at some institutions. At UVA, we've taken a practice of not using a lot of what we call in-your-face BPAs. They don't pop up, they're not on screens. We have a lot of our more passive BPAs, which appear in my plan and kind of are like yellow highlighted to remind me of these things. The other things that I know a lot of primary care doctors do is, Epic at least has the sticky note function. And so a lot of people will put kind of reminders to themselves about the sticky note function and things like that. And then more recently, we're getting ready actually to turn on a function in Epic, hopefully in the next month or two here, about med adherence. So you'll actually be able to see on your med list a green check mark, a yellow question mark, or a red, which will actually show up on your med list, and it'll show you, yes, this patient's getting this medication filled. We know they're getting it filled versus like we don't know, or this medication definitely we've had no claims to it. We don't know that it's being filled. So I think that's going to help us with our value-based metrics around cardiovascular health, the statin adherence, things like that.
It's an excellent, I'm actually looking forward to that. I wasn't aware, so this is great. I had a patient this morning, only primary prevention, but her statin hadn't been refilled for a year, and she swore she was taking it, but I think she was mistaking it for a different medication. And so this, I think those kinds of things can help us better make sure. Sometimes it's hard to do the extra digging and get past that inertia of trying to make sure that patients in it, if we're checking LDLs and checking lipid panels, that can help with some of that adherence, but there may be more subtle things that we can do that can help providers. So that's excellent. I'm going to move us on to the second scenario, similar, a slightly different twist to provoke a slightly different discussion. So this is our same 64-year-old man with type 2 diabetes and hypertension, and he is got coronary disease, but he's had this for a long time, and he's coming in to seek care with a new primary care physician to initiate care. He's recently moved to the area. He's currently taking rosuvastatin 20 milligrams and ezetimibe 10 milligrams daily. And so Dr. Daldell, this is kind of in your world now. And I want to kind of focus on the discussion of resource limited environments. And so how do you approach patients in terms of when they're coming to establish care and their ongoing cardiovascular needs?
Right. So, I think this type of patient who comes into my office, I'm really doing an assessment of what's the current state of his cardiovascular health. What are they having any symptoms? Is he having any exertional dyspnea? Is there anything that would make me think that there's ongoing cardiovascular progression of his known coronary artery disease? If the answer is yes, then, I think at that point I would probably go ahead and in this health restrained environment, a lot of times I'm doing the stress test myself and then also referring to cardiology at the same time so that they can have kind of the best first visit. If, however, the answer is no, this is a really stable patient, they had their MI 15 years ago, and they've been doing the kind of yearly check-in with their cardiologist where the cardiologist says, yes, you've got good blood pressure control, you're on the right medications, and your LDL is still really well controlled. I might hold on to that patient as my own and not refer him immediately, because we do have a lack of specialty care across this country. It's getting harder and harder for primary care to refer to our specialist colleagues. And if this is just going to be another appointment where they're kind of taking over and then seeing yearly, that's backing up my patient who really has active disease and not able to progress into the system. So the nice compromise that we have at UVA is we do have e-consults for our primary care providers to access our specialists. And so I've definitely had the patient once or twice where I'm like, this could be a referral, or I could just go get the stress test and then decide afterwards. And my cardiology colleagues are very happy to answer these questions, with, what are the next steps? And then this is the type of patient where when they first come in, I'm definitely checking that LDL to make sure that we're under 70 and appropriately controlled. And if we're not, then we start having those conversations about dose escalation of their rosuvastatin, and are we able to kind of maximize that further, as well as, what's their hypertension look like right now? Are they well controlled? Are they less than 130 over 80? Or are there other medications that we need to add to further maximize that? Those are all things I, as a primary care doctor, feel really comfortable with. But what I've learned over time and kind of some of my other roles is primary care, the breadth of primary care is very broad, and not everybody got the cardiology training that I got. And so they might not feel as comfortable. So we have to respect that some of our colleagues, some of my own primary care colleagues, might not feel as comfortable with that management as I do. And so that's where at UVA, the e-consult's kind of nice, because if people feel somewhat comfortable, they can get the help from their specialist colleague. But if they don't feel comfortable at all, then the referral's made, and our colleagues here are super gracious and happy to help. So that's kind of how I approach it.
Just for the uninitiated, can you just briefly describe the e-consult process? I'm not sure how widely it's used across the country.
Yeah, so an e-consult at UVA, I will say, is completely asynchronous. So it's actually an order in Epic that I fill out. It has some templated guidance for different conditions that are common to get e-consults. So for this one in particular, it'd be, established coronary artery disease. I'd write a brief clinical narrative. It would likely ask me for their most recent blood pressure and LDL, and then I would send it on. And then it goes to a e-consult pool in cardiology, and the e-consults are answered by that specialty. They write their answer back. So it's almost like using email in a way. They write their answer back and they send it to me. And I typically get that response within 3 to 7 days. And then I'm able to go forward with the plan that they kind of let me know, or a lot of times they'll be like, yeah, I totally agree. If the stress is abnormal, like if this were a case where I felt like I needed to get a stress test, if the stress is abnormal, definitely, go ahead and send the referral, that kind of thing.
Absolutely. Great. Thank you. Dr. Rodriguez Lozano, what are the red flag symptoms that would prompt you to recommend referral to cardiology in this situation? And particularly, I'd love for you to focus on maybe sex-specific characteristics, because we know that heart disease in women is a very different beast.
Yeah, thank you, Dr. Kirby. I think there are probably different scenarios that a patient needs to be seen regularly by a cardiologist, and I totally agree with Dr. Dowdell that we need to empower our primary care physicians, because there are many patients with chronic cardiac diseases, and not everybody have access to a cardiologist in the immediate fashion as we would want. I mean, sometimes you put a referral and the waiting time can be from weeks to a few months. So I'm totally agree with her. But there are maybe some patients in, like I said, in specific scenarios that maybe they need to be seen by a cardiologist. And those are patients that have complications, or they have maybe developed heart failure, or they have significant valvular disease, will be one group. Another one will be patients that they are at high risk for recurrency, or they have history of several MIs in the past, maybe history of in-stent restenosis. They have several procedures. I would say even patients that have history of CABG or valve replacement probably are the ones that they need to be see a cardiologist regularly. Then if patients like Dr. Dowdell was saying, checking their LDL and they are good, I keep following. And maybe, I mean, depending on the comfort and expertise of the primary care physician, many of our primary care physicians, including Dr. Dowdell, she feels very comfortable starting non-statin agents. And we're probably going to talk about later on, but also if we have patients that they are, you know, their LDL are very resistant to getting gall. So many times they are escalated to a cardiologist to help with that management, especially patients that have genetic disorders related to their cholesterol. They might have familial hyperlipidemia. So those patients are sometimes more challenging to manage. And then of course, patients that have new symptoms, like Dr. Dowdell was saying, new symptoms or worsening of symptoms that depending on their severity, I think many primary care physicians, they feel comfortable ordering that first stress test, maybe with the help of an e-consult, maybe just by themselves. But then when you get in that area that the symptoms are severe, for example, they are occurring with minimal exertion or even just at rest, you think maybe the stress test will be not enough, and you're thinking maybe this patient needs an invasive assessment as an initial testing. And if that is the area that you think this patient is falling on, I mean, I think a referral to a cardiologist will be totally reasonable. And like you were asking, there is sex-specific differences in the presentation of specifically women with ischemic heart disease. I mean, many women, and in general women, sometimes we present in a different way. We do have chest pain, but we have other associated symptoms like shortness of breath, or maybe even severe fatigue for months before you present with an acute event, and even symptoms that are triggered by emotional stress. And you know, the providers, sometimes we get distracted, not only primary care physicians, but as a cardiologist, and we start just hearing severe fatigue and emotional stress, and we forget that also that women was talking about chest pain, right? So I think, unfortunately, data have shown that women are less likely to be treated with optimal medical therapy, and they are less likely to be to have a revascularization therapy. And women, we have also worse outcomes, and I think it's because of that, and that is important to be aware of that bias.
Yeah, excellent. I was very privileged to be trained by a couple of diabetes doctors, experts who focused on cardiovascular risk reduction, and learned very early on, particularly with women, it may just be like, I'm just not able to do what I normally do. And I have a very low threshold, particularly in the setting of somebody who has known cardiovascular disease. I had a patient of mine who I kind of pushed her cardiologist, and it turns out she needed an intervention, and ended up getting stented for a couple of lesions that were problematic. So I think it's a good reminder for all of us, and it always is a good reminder for myself to be thinking that way. In the interest of time, I want to move on to our last scenario, and this is kind of more in something that I would see, which is a gentleman that comes in with his diabetes and hypertension. He's coming in to see me, and honestly, there are patients that I may see more frequently even than their PCP, if I'm seeing them every 3 to 6 months for their diabetes management. And I view part of my world is doing cardiovascular risk reduction for these patients that, you know, in addition to what we share with other specialties. And this is somebody who's intolerant to statins. So we have these patients currently taking the 10 milligrams of ezetimibe, but his LDL is not at goal. And so we talk a lot about, you and I and Dr. Dowdell, we have spent a lot of time talking about how we interact as colleagues. And I would argue that outside of just cardiology and the PCP world and endocrinology, that we also have our nephrology colleagues and our neurology colleagues, all of us who share in that responsibility for cardiovascular risk reduction. We talked a lot about things like management of hypertension, LDL reduction, targeted heart failure therapies. And there's a lot of medicines that now fall into all of our bailiwicks. Cholesterol medicines, when SGLT2 inhibitors in particular, and how do we break the inertia of starting these medicines and making sure that we're communicating with the right providers and not necessarily deferring in that moment, and who's going to take that responsibility? I find this, I tend to be much more proactive in a setting like this, where I feel very confident and comfortable doing cardiovascular risk reduction to a point. And then activating my help chain with my cardiology colleagues or others. But I'm curious, Dr. Dowdell is a PCP and your patient's seeing 3 or 4 different specialists. How do we best communicate with you without overwhelming you? Because we're all inundated with our EMR inbox.
Yeah. So, I always appreciate the CC'd note that has a note attached to it, right? So it's like, hey, and I think I just did this to Dr. Rodriguez-Lozano the other day, where I saw this patient and this was for primary prevention, but I know she needs to be on a statin. I can't get her on a statin. So I sent her my note to her being like, I got the cardio IQ panel and please talk to her about this statin, and she was able to do it. So direct communication, the CC'd note that has no communication to me is not super helpful, because then I have to read through it and do that kind of thing. But I do think that when we send the note with hey, I want to do this, or FYI, I did this, even better, then that really helps with the patient's care and moves them along. I know you and I, Dr. Kirby, tend to try to see our patients kind of you see them and then I see them probably 6 weeks later type deal. And so, we've made a lot of med changes where it's like, hey, I made this med change. Can you follow up and make sure they're tolerating it? And that's worked really, really well for us. I will say it's harder when the cardiologist is outside of the system. I don't feel as empowered, to be honest with you, to change the medications. Because I don't have a great way of communicating with that doctor who's outside of my EMR.
Yeah. I think you make great points. I'm going to give Dr. Rodriguez-Lozano the last word here. Specifically, I think this is a great patient that a PCSK9 inhibitor would be potentially a next step, although there's the bempedoic acid data that just came out. I think a lot of us have deferred that start to cardiology world, and I just wanted to get your take on that in the last couple of minutes here.
Yes, I just want to say that managing dyslipidemia is a teamwork. So everybody should be involved. It's not only cardiologists. I think the primary care doctors, the endocrinologists, the nephrologists are seeing that patient. We all should, take on this, because it's not an easy task. The other thing that I will say, talking about this specific patient, is that every time we manage dyslipidemia in a patient with established ASCVD, we have to think about this is secondary prevention, and we want to know how the risk of that specific patient, right? It's a very high risk, it's a high risk, because the LDL target is going to depend on that. I mean, we have data already, we have new guidelines on 2022, we have the European guidelines since 2019 saying patients with high risk, their LDL should be not less than 70, but actually less than 55. So lower is better. And now, like you were saying, we have different medications that we can use. I think most of primary care physicians, they feel comfortable with the statin, of course, ezetimibe, PCSK9 inhibitors. I think the problem is not feeling comfortable because it's not much, just prescribe the medicine. Sometimes it's getting approval from this from the insurance to cover these medications in particular that needs an extra step like a pre-authorization process. And our pharmacists, they do this all the time. So many times I think the referral is not because I don't know that I have to use this medicine, it's because of the insurance coverage, and we are happy to help with that. Now, like you were mentioned before, we have new drugs, and we have specific drugs that we use for patients with familial hyperlipidemia, especially if we have homozygote patients with this condition, because it's harder to manage them because their LDL is really high. So probably in these cases, cardiology will be the ideal person to manage these kind of patients, because we can talk about other kind of drugs and escalate, as you were talking about. We have new kids in the block that statins and PCSK9s, they are not the only alternative for patients that they have resistant LDL or that they are intolerant to statins. We just have in ACC meeting on March, and we have like this bempedoic acid that is an oral agent that is very promising, especially in patients that they are intolerant to statin medicines, and now we have outcome data. So we know that that is definitely something that we should consider, and we are prescribing that currently in our clinic.
Awesome. I'm going to end there and give us enough time to do questions. So I'm going to turn this back over, I guess, to Tasha.
Well, thank you so much, Dr. Kirby, Dr. Dowdell, and Dr. Rodriguez-Lozano for your presentation. At this time, I encourage our participants to type their questions in the Q&A box. And we will get started with our first question. What are some of the strategies that you employ to address misinformation, especially for statins?
Yeah, I'm gonna tap Dr. Rodriguez-Lozano because I think she's probably our best expert. I will put in here that we all need to be doing this. This is important because I think the statin fear is very real. I just had a patient yesterday, type 2 diabetes. It's for her primary prevention, but she really needs it and is very resistant. So yeah, Dr. Rodriguez-Lozano.
Yeah, so I think it's, I think education actually empowers patients. I think first of all, we know that side effects from cholesterol lowering drugs are pretty minimal. I think in general, we have now, we know, of course, the ones that patients, they are more worried about potential side effects are the muscle aches. But we have multiple studies now showing that many times when they look at this and they compare patients that were statin versus placebo, actually it's almost the same prevalence of this side effect. And now we describe this nocebo effect, meaning that it's just more, it's about like thinking that a negative situation is going to happen or a negative outcome just because you believe that that intervention is going to cause harm, right? So I think showing this data and sharing this data with patients and sharing with them what is really the benefit of the medicine that they are taking, especially statins, I think that will empower them. And of course, I think like just a close follow-up, many times I ask my pharmacists specifically to follow up with them regardless of them calling back or not, if they are tolerating the medicine, just to make sure that they feel that they are supported. And if they have side effects, just to address them immediately, because you don't want patients to discontinue the medicines without you knowing and just find out in a year, oh yes, I stopped the medicine after a month because I have all these side effects. So why you didn't call the office, right? And we can address it and look for another alternatives.
Yeah, I can't agree enough about how valuable a clinical pharmacist or anybody following up on a medication start can be. I have a clinical pharmacist that we work with who's been invaluable for following up and adjusting, especially for medications around diabetes. So absolutely, I think it's a huge piece of this. So props to my clinical pharmacy colleagues.
Yeah.
Wonderful. Our next question is, what are strategies that you use to obtain approval for newer agents such as PCSK9 inhibitors?
Dr. Dowdell, have you tried?
I will say that I got approval once using an e-consult for to basically, one of our Medicaid programs here almost requires a cardiologist in order to get this approved. And so I did an e-consult. The e-consult said, yeah, we agreed. This sounds like a good case for this, and we were able to do that. Really, what I've started doing in Epic actually is keeping in the overview of the problem. I've started keeping a list of like which statins we've tried, what the max dose we could get to was, and then also like why we had to discontinue it. And I've found that that's been helpful, at least with my nurses who are helping me try to do these prior authorizations, so that it's very clear to everybody, like this is the history of this statin use in these patients and why they're not tolerating it. Admittedly, I haven't used it for patients who aren't getting to goal and are on statins. More often than not, my patients that I'm trying to get this for are the patients that have not tolerated multiple statins.
Dr. Rodriguez Lozano, what's been your biggest barrier in terms of getting approval for these medications?
So I think it depends on the insurance coverage. To be honest, it varies depending also if which commercial insurance, for example, you have. Sometimes in our clinic, we have a system of like a copay card, so that helps in many times. I mean, our pharmacists, they know, and they're very knowledgeable about these different techniques to help patients. And so, I mean, it shouldn't be that you refer a patient to a cardiologist just because you're not able to get the medication approved. I think Dr. Dowdell has been really smart using all these different resources, and e-consult, I think, is a good alternative if you have it in your system, or you have a different way to communicate with your cardiology team, because I think, we should help each other to try to get patients in optimal medical therapy.
Anything specifically around Medicare patients? Because I know that's a lot of the population that we tend to care for with these high, or that have risk or known cardiac disease. I think Medicare can be particularly challenging because you can't use copay cards. And the Part D coverage can be really variable. Plus I know that in 2025, with the Inflation Reduction Act, having caps on out-of-pocket costs will likely make a huge difference for a lot of the medications that have shown value. Heart failure, cardiovascular risk reduction, diabetes, those things. I think that's going to be exciting. But I think Medicare in particular has its own challenges. And if you have any other comments.
Yeah, many times, like I said, pre-authorization process is necessary and it's a pain, but we'll do it, and that is the only way to get it approved.
Yeah.
Yep.
Yeah. Thank you.
Great. Our last question, what is your approach to overcoming inertia in starting and escalating therapy? Are there EHR strategies that can help minimize inertia?
Dr. Dowdell, I'm going to throw this out to you in the last like 90, 30, 60 seconds. So, yeah.
Yeah, so I think there are EMR programs. We are currently working on a primary prevention program for cardiovascular health, but also this could be applied to secondary health. You really have to, know your EMR and know what the tools are that it has. So for Epic, there are a lot of tools out there. There are BPAs, there are registries, there are health maintenance reminders, there are smart sets that you can engage, there are order sets that you can engage. The biggest barrier, I think, for a lot of these things is getting the problem on the problem list, because so many of them are driven by the problem list. So if your problem list isn't accurate, then it's hard for this to work. But with cardiovascular, at least there is a lab value you can look at. And Epic does a good job of calculating ASCVD risk. So for primary prevention, the computer can actually calculate that for you and then flag you. For secondary prevention, as long as you've gotten the problem on the problem list, this and can get a patient into a registry, you can engage a lot of different Epic tools to do this. I think the biggest inertia component is, at least at our institution, is getting the Epic resource to actually build what you envision. And if you can engage that resource, either by promoting, your value-based care metric or a contract that you might have with a payer, then I think that will give you the most bang for your buck.
Well, thank you so much, Dr. Kirby, Dr. Dowdell, Dr. Rodriguez Lozano, for this great presentation, and thank you to our audience for your participation. Coming up next at 1:30 p.m. Central Time, you will have the choice of 2 sessions. Track 3A, Alert Can Clinical Decision Support Tools Prompt Better Quality ASCVD Care? And Track B, Benefits of Integrating Pharmacists in ASCVD Management. At this time, please use the Return to Lobby link on your screen to choose your next session from the presentations list. Thank you very much for attending today's virtual summit.